Well, good evening to everyone. I just want to say thank you very much for attending today's webinar, the 20% Scleroderma men. And I want to thank very much to the doctor and to Michael, my co-host on this webinar. And I will be running basically the presentation, and I will let Michael do the speaking to introduce our doctor, and I will be on mute. But at the end, please wait till the end of the presentation so we can ask the questions, and we'll go back to the slides if it's necessary for you to bring up a point. So thank you very much, and I will let you take it away, Michael.
All righty. Thanks, John. I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based 2019 educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members whom seeking to obtain accurate information about scleroderma. There are individuals from all over the world participating in this webinar, emphasizing that we can be connected and sit in front of our computers while staying in our homes and offices. This is the 4th webinar in the series and focused on the male scleroderma patient. There will be 2 more webinars presented in 2019 and can be located information about them on the Michigan Chapter's website. If you'd like more information about these, you can find the information in the National Weekly E-Blast or in the Michigan Chapter's website, which is all small letters, and Michigan is spelled out, scleroderma.org/Michigan. This evening we have with us a presenter, as our great presenter, Dr. Vivek Nagaraja. And Dr. Nagaraja is the clinical assistant professor in the Division of Rheumatology and an active facility member at the Michigan Medicine Scleroderma program. Originally from the city of Bangalore in India, Dr. Nagaraja received his medical degree from Ramaya Medical College. He did 2 years of transitional post-doctoral training in the United Kingdom. He subsequently moved to Tucson, Arizona, where he completed residency in internal medicine and fellowship in geriatric medicine at the University of Arizona. He then completed a fellowship in the rheumatology at the University of Michigan in 2014. He became a facility assistant professor at the University of Toledo and rejoined the University of Michigan Division of Rheumatology in May 2017, and is an integral part of the Scleroderma program. Dr. Nagaraja brings a unique geriatric clinical experience of chronic care management into the care of scleroderma patients. He is board certified in internal medicine, geriatric medicine, and rheumatology, and a member of the American College of Rheumatology. His specific research interests include patient-reported outcomes, measurements in rheumatic diseases, including scleroderma, and their implementation into, routine clinical care, and understanding the unique subset of patients with rheumatic diseases who have interstitial lung diseases. He leads clinical trials in scleroderma at the University of Michigan in partnership with Professor Dr. Dinesh Khanna. The Scleroderma Foundation Michigan Chapter thanks him for sharing his time to present this males-only webinar this evening, and we look forward to learning more about how scleroderma affects our population. Thank you, Dr. Nagaraja, and it's all yours, sir.
Thank you, Mike. That's a very nice and a generous introduction. John, thank you for putting up with all the slide arrangements. I do apologize for the last minute delays. I would like to thank Michigan Chapter Scleroderma Foundation and Laura Dias for inviting me to present and share information, one specific to systemic scleroderma and 2 more specific to men with systemic scleroderma. This is my second talk or a webinar, which the last time I gave was back in February of 2018. And I have made as much effort possible to update some of the slides, but have retained a lot of them because I feel some of the integral aspects of self-management and approach to having this diagnosis, I feel, are important when I share this information. So next slide, please. So I would like to start with what is scleroderma, because commonly I have patients coming in from across the state and from 4 states around Michigan and around the country, and they're either ill-informed about scleroderma, or they have read quite a bit about it and somehow applied all that information to their medical condition and their symptoms. So it becomes important to try and tease out what they have understood, unlearn, relearn, educate. So all these are important. The scleroderma, the word scleroderma was coined is a Greek term. It was coined in 1836 by an Italian rheumatologist. Scleros meaning hard and derma meaning skin. It is a chronic autoimmune disease. Now, auto is a word we use for self, and immune system attacking the self is what we call autoimmune disease. There are thousands of autoimmune diseases, and many examples include things like Hashimoto's thyroiditis, autoimmune thyroid disease, autoimmune liver disease, type 1 diabetes. But you also have other group of autoimmune diseases like we see in rheumatology, like rheumatoid arthritis, systemic lupus, Sjogren's disease, and scleroderma. The key distinction between a single organ autoimmune disease versus a systemic autoimmune disease is the fact that in rheumatology, many of these autoimmune diseases, the immune system tends to not only attack one single organ, but can target many organs. So that's why we call scleroderma a systemic autoimmune disease, wherein the primary target is the skin and the tissue beneath the skin, but you have other internal organs that can be affected, like lungs, the gastrointestinal tract, kidneys, blood vessels, the fingers, toes, and there are other rarer manifestations. Next slide, please. Now, I do want to make a distinction here about what is localized scleroderma, which is also called morphia, and systemic scleroderma. Now, localized scleroderma, I tend to like to use the word morphia for the distinction and taking off that word scleroderma, because in localized scleroderma, the main affection is that of the skin and the tissue beneath the skin. The pattern of skin involvement is different compared to systemic scleroderma, and we often do not see internal organ involvement. So the term localized scleroderma I'm going to use only for this slide. The rest of the talk is going to focus only on systemic scleroderma, wherein there is skin plus internal organ involvement. Now, systemic scleroderma can be of two broad categories based on extent of skin involvement. I'm going to underline that phrase, extent of skin involvement, not extent of internal organ involvement. So we call limited skin involvement, or what we call limited systemic scleroderma. Another term is limited systemic sclerosis. If there is involvement of the skin in the hands and not going beyond the elbows in the upper extremities, not going beyond the knees in the lower extremities, and only face. So if you have this pattern of skin involvement as determined by a rheumatologist, then we call it limited systemic sclerosis or limited systemic scleroderma. In diffuse, you pretty much have quite diffuse involvement of the skin all over. Now, next slide, that's fine. Some facts are important to understand the needle in a haystack kind of a prevalence of systemic scleroderma, yet having quite magnanimous impact on the life of patients affected by it. Now, as of today, the US population is 327. I took the decimal out. I think it was 327.5. The estimates of scleroderma per se, that's systemic and localized included, is about 300,000. Now, I should warn you that some of this prevalence data are quite old, and there are efforts being made currently at a national level to relook at what is the prevalence estimates. About 80 to 100,000 of this 300,000 are patients with systemic scleroderma. So really 2 to 3 in 10,000 US population. So when you compare this to something like diabetes, wherein it's almost as high as, I think 1 in 5, almost 20%, this is a very rare condition. Next click. Now, the age range usually described is around 25 to 55 years, but we have seen patients on either extremes. We have seen some young girls, commonly in their late teens or early 20s, and we have seen older patients. Some of my oldest patients are even in their 80s. Commonly affects Caucasians, at least in the United States. Next click. And it's commonly in women, and that's where we are here to talk about the distinction. What are the things that might be pertinent to men? Next slide, please. Again, I just want to highlight this terminology because this is important for our patients to understand. The terms limited and diffuse are used to describe the extent of skin involvement, not the involvement of internal organs. Next click. And again, this is the distribution that I talked about. Next slide. Now, there are some key features in patients with diffuse systemic scleroderma. These are some photographs from a review that was put together by Professor Denton in the United Kingdom and Dr. Dinesh Khanna. Now, in this gentleman on the left has diffuse scleroderma. These are some facial changes. And now you can see that he has not made an effort to automatically open his mouth. He's just not able to completely close his mouth. There is a decrease in the oral aperture. There is that shiny skin that you could see on the forehead. You do see some creases, but overall you can see a bit of a skin tightening that you can appreciate on the face. Picture B and picture D show changes that happen in the hand and the upper extremities. Now the hands, they're diffusely swollen. So that's in a very early phase of the diffuse scleroderma. He is unable to make a fist. That's the most he can bend his hands. And he has contractures or difficulty in straightening out the elbows due to thickening and hardening of the skin. In the picture C, you see changes in the legs, where there is loss of hair, especially in the lower part of the legs. And the red areas that you see are again areas of skin thickening, along with areas, the white areas also being involved. And this is very tight skin seen in the early phase of diffuse scleroderma. Next slide, please. In contrast, we have some changes that we see in limited scleroderma. In this gentleman to the left, you do see some shiny skin, but you see a whole lot of red spots in the face, what we call telangiectasia, or these are superficial dilated blood vessels. On the hands, on the other extent, you can see the veins on the back of the hands. And there is puffiness of the fingers. There is skin thickening mainly confined to the fingers. And in picture C, which actually applies to both diffuse and limited scleroderma, there are changes seen in the capillaries adjacent to the nails. The capillaries are commonly dilated, and this is pretty much seen in almost all patients with scleroderma. And there are different phases in how the capillaries look like. Next click. So there is internal organ involvement in systemic scleroderma, and this is a list, and I will be dwelling into each of these in some detail through the talk. So in terms of the skin, you see thickening, hardening, fibrosis to varying extent. In terms of the blood vessel or a vascular involvement, almost all patients with scleroderma have Raynaud's phenomenon characterized by color changes in the fingers associated with symptoms. In addition, they can have what we call pulmonary arterial hypertension or high blood pressure in the lungs. Now, it is very different to high blood pressure we talk about in general terms. In lungs, you can have lung fibrosis or what we call interstitial lung disease. Now, up to 80% of patients with systemic scleroderma, irrespective of the diffuse or the limited kind, can have interstitial lung changes. However, about 50 to 60% can have lung fibrosis on CAT scan. In terms of heart involvement, some patients can have fluid around the heart, what we call pericardial effusion. And rarely there could be heart muscle involvement to varying extent, causing either heart failure, or it can also affect the electrical system of the heart, wherein patients can have conduction system problems in the heart. Up to 90% of patients with systemic scleroderma can have gastrointestinal tract involvement. And this could be anywhere from the mouth all the way to the rectum. Now, kidney involvement was seen more commonly in the past. It's still seen. The awareness is more, the recognition, we try as best as we can to pick it early. But in its worst form can cause renal crisis. And in terms of joint and tendon involvement, we can see joint inflammation, we can see inflammation in the muscles at times, and we can see joint contractures. Now, some of the miscellaneous things that can happen alongside are calcium deposits in the fingers and various different areas of the body, what we call calcinosis, the telangiectasia that we talked about, the small red spots on the face, on the hands, on the lips, etc. Next slide, please. Now let's step back for a minute and focus on this concept and reality that systemic scleroderma is not one single diagnosis. It's actually a family of conditions that can vary between individuals, but can be classified into 4 broad categories. For next click. The first group of conditions that you can see, and this includes CREST syndrome, is the limited systemic sclerosis or limited systemic scleroderma. As I said, there is limited extent of skin involvement as determined by the rheumatologist. Patients often have Raynaud's phenomenon for many years preceding the skin involvement. Late-stage complications are frequent, like pulmonary arterial hypertension and bothersome gut involvement. Now, that's why we have the rheumatologist checking your echocardiograms many times, almost every 1 to 2 years, along with lung function tests to figure out if you have any signs of pulmonary hypertension. Next click. Then you have the diffuse systemic scleroderma or diffuse systemic sclerosis, wherein there is diffuse skin involvement, again, as determined by the rheumatologist. There is a short history of Raynaud. So often the story would be something like the Raynaud started a couple of years or a year before the skin thickening started. Sometimes I've even seen patients when the Raynaud has started concurrent to the skin changes, or they've started noticing it after the skin changes started. So you can have all of these varieties. There is an increased risk of internal organ involvement early on in the course of the disease, especially that of the heart, the kidneys, lungs, etc. Next click. You have this rare form called Cine scleroderma systemic sclerosis, wherein you don't see skin involvement. Now, this diagnosis is quite challenging, and often the initial presentation could that be of severe Raynaud's plus or minus involvement of internal organs. Some examples of patients that I have in my care are those who presented to the ER with renal crisis or kidney involvement, and then other manifestations or other symptoms started, and then a few months or years later they were diagnosed with Cine scleroderma. Now, one thing is they could often have abnormal or scleroderma-specific blood tests or antibodies, mainly either anti-SCL70 or anti-centromere antibody or anti-RNA polymerase III antibody. They almost often have abnormalities in their capillaries around the nails. And as I said, internal organ involvement is often present. Next click, please. Now, even more challenging at times is when the immune system kind of tricks us and presents as 2 different rheumatic diseases in the same human body. Now, this can be quite challenging in trying to understand which of the conditions is dominant, which of this is taking an upper hand, is it codominant, because all of these have impact on A, the diagnosis, B, prognostication, and C, treatment and the choice of treatment. Now, amongst overlap syndromes with systemic sclerosis, one, patients will have systemic scleroderma, either limited or diffuse, and in addition could have systemic lupus or rheumatoid arthritis or myositis, and management and education becomes all the more paramount in these situations. Next slide, please. Now, here is a modified natural history graph about the timing of different manifestations. Now, the upper line, the upper curve, pertains to patients with diffuse systemic scleroderma, and the lower curve is for patients with limited systemic scleroderma. You have skin thickness on one axis and the disease duration on the other axis. Now, if you see for diffuse scleroderma, the peak skin thickening happens very early, often in the first 6 to 9 months. And internal organ involvement is also very early, as marked by the red box. Over time, it could be over the next 2 to 5 years or 3 to 5 years, there is stagnation in the skin thickening with gradual decrease in the skin thickening. I should warn that although the skin thickness improves, some of the hardening of the tissue beneath the skin may not, which can be experienced by many patients wherein they feel that the skin is softened, but they're still finding it hard to make a full fist or have full range of motion in some of the joints. Now, what we see in this big curve is a mix of patterns, as has been shown in many of our clinical trials, wherein some patients can have a peak way too early within the first 6 months and then start softening quite fast with treatment. Some might have a later peak and then soften. So you can have all kinds of mixtures, but this is usually the kind of pattern we see. In limited systemic sclerosis, the skin thickening is very gradual and the peak is much lower in terms of the skin score. Now, skin scoring is done with what we call a kind of a specialized pinch test that we get trained and certified for, also called a modified Rodnan skin score. So again, coming back to the limited systemic sclerosis, the skin thickening or the skin score, the peak is low and the increase is rather gradual. The internal organ involvement is a bit later in the course of the disease, especially things like pulmonary arterial hypertension, severe GI involvement, or even malabsorption. Next slide, please. With this brief introduction about the multi-systemic nature of systemic scleroderma, I would like to dwell a bit into detail of what's different in men. Now, this choice of this photograph is very intentional because we are only touching the tip of the iceberg. Next page, please. Next slide, please. Now, the gender differences in scleroderma. Now, in the past about 3 to 4 years, there have been interesting studies from different cohorts, primarily Europe, Spain, and some of those areas, wherein they have looked at gender differences in people with scleroderma. And what has been reported is the age of onset in men is older compared to women. Higher percentage of patients have diffuse as opposed to limited form of systemic scleroderma. And in limited scleroderma in men, there is more frequently active disease in the form of internal organ involvement. The presence of this particular antibody, anti-SCL70, is more frequent, and this has been associated with lung involvement in systemic scleroderma. Muscle and lung involvement is frequent, and this could include muscle inflammation, joint contractures, some of the muscle weakness, and also the lung involvement. There has been a lot that's looked into the relation with occupational exposure, like organic solvents, rubber, etc. Next click, please. There have been links looked into cigarette smoking, and both on the potential incidence of scleroderma and the association as well as longer-term complications. Now, again, the lung involvement in the form of lung fibrosis or interstitial lung disease and pulmonary arterial hypertension seems to be more frequent in men. Now, all of these should be underlined by the caveat that the percentage of men in these cohorts is not a lot, yet it's a substantial number when we compare to other studies. So this is useful information, but there is efforts being put in to prospectively look into data on how the gender differences differ and how we can tailor treatments. Next slide, please. If you could go back to the previous slide, I just want to point out that the timing of onset for the lung disease and pulmonary hypertension is somewhat of a shorter time of onset. In other words, from the onset of the skin involvement to the diagnosis of some of the lung involvement, the time of onset is somewhat sooner compared to women. Next slide, please. And what we certainly want to talk about are the appearance changes, altered facial features, skin tightening, telangiectasia, changes in pigmentation in terms of either darker pigmentation or lighter pigmentation, and hand contractures. These all are quite common in patients with systemic scleroderma, also in men. The question is, are these bothersome? Next slide, please. I would say yes, of course. And it's quite obvious to our patients, but this was also looked into carefully in the SPIN cohort, which is a scleroderma patient-centered intervention network, which was a multinational study in Canada, UK, and USA, 21 centers, large number of patients. There was clear, so they surveyed on the distress due to appearance amongst many other things. And next slide, please. The 12% of the population were men, and of them, clearly over half reported concerns of their appearance and how it caused distress. 85% of Black patients or African American patients reported concerns. And interestingly enough, we do see quite often and quite significant hypopigmentation or lighter skin color changes in people with darker skin, primarily because of the melanin pigment involvement or the pigment layer involvement. Next click, please. And this also led to a greater amount of total body image dissatisfaction. So the areas of the body wherein these color changes were commonly seen were in the face, the head, the hands, fingers. Next slide, please. Now, before I dwell into how to try and approach, and this is based on very detailed conversation with my patients that I've had, some of them who have taken it greatly on their stride when they've had this diagnosis, and some of them obviously were quite distressed by it. Scleroderma is a chronic condition. Chronic condition by definition does not have a cure, and I'm going to say as of today. This is one of the most exciting phases in the research in systemic scleroderma that we have had in the history of medicine. And I think great strides are being made and have already been made in the past 10 years, and we are definitely heading in the positive direction. And our hope is to eventually have some kind of a cure for this condition. It is rare, and it is important to note that it's a very diverse set of family of conditions. So what may apply to one person may not quite apply to the other. And this is an important point for me to make, especially for people who are proactively involved in patient-based foundations. Next click, please. The most important person in the care of scleroderma is, of course, the person with scleroderma, who partners quite well with, of course, their caregivers, their rheumatologist, their primary care physician, and many other specialists depending on the internal organ involvement. So it is a team-based care with a patient-centered focus. And it makes us very happy as rheumatologists who take care of scleroderma patients to be giving these kinds of talks, because a place like Scleroderma Foundation has really been a self-advocating, empowering organization for our patients. So empowerment of patients or persons with scleroderma to be their own advocates is one of the key things that we try to educate our patients. In fact, at Michigan Medicine, University of Michigan Scleroderma program, we have something called peer mentorship program, wherein new patients diagnosed with scleroderma are offered to be in contact with patient volunteers who had scleroderma for varying durations of time. And they kind of are their peer mentors in talking through, listening, reflecting on the experiences of persons going through the symptoms of scleroderma. So we have mainly female patients, but we are starting to slowly build a network wherein we can have a mix of patients with all different forms of the condition. Next slide, please. Now, it is important to recognize both for the persons with scleroderma, their caregivers and loved ones, as well as the providers participating in their care, on the impact scleroderma has on different roles. So it could be the domestic role as a partner, a son, a parent, a friend, a sibling. And it is a conflict that one has to go through with their own self and mind. The common questions that come to them, our patients, are why me? As in, especially this happens if someone has been very healthy, physically active for a while, and all of a sudden they have these new symptoms and a new diagnosis. The questions then follow along. Did I do something wrong? Will I pass it on to my kids? There is that sense of shock and disbelief up front, depending on how severe the symptoms are up front. There is a sense of anger, because it could be anger against the condition, the health system, the research, and the lack of diagnosis, the delay in diagnosis, or the lack of a cure available, and associated with some denial and sadness. All of these complex reactions can follow in sequence. They can occur at the same time as with any of our other chronic medical conditions. And all of these are compounded by what patients read online, as there is a lot of misinformation, at the same time information that they think might pertain to them but may not be completely accurate. Next slide, please. I would like to briefly go about some self-help tips, and this is again what I have learned quite a bit from taking care of patients with chronic diseases, patients diagnosed with cancer, patients diagnosed with dementia, talking to caregivers, and of course learned a lot from our own patients with scleroderma. Now, it is important to be open and talking it out with close friends and family whom you trust at the time of diagnosis, to voice out your feelings. Next click. And it is helpful to build a supportive network early on, and that's exactly where places like Scleroderma Foundation make such an important or have such an important role as a support network. Next click, please. And you can go ahead and click all the points, and I can highlight some of the important things. Now, some of these factors are very important up front. And this I kind of emphasize in any person with a new diagnosis of a chronic disease. It is important to bring some kind of a principled or a discipline to your life, as all these might have small and important contributions to start to feel better and cope with the diagnosis. So the first thing is try to avoid over fatigue, be it at work, be it with a family life, as best as you can. It's easier said than done. Learning to focus, learning to try and manage stress, eating food at the right times, and I'll come to some of the approaches that you have to take with GI involvement. Adequate sleep is an important thing, and practicing good hygiene habits, especially for the skin, the teeth, and the gums, especially the hands and feet in case there are ulcers in the fingers or toes. Next click, please. And most importantly, people who smoke, please avoid smoking. it has further adverse impact as you continue smoking through the diagnosis and treatment. Next click, please. There have been recent data in rheumatic diseases and also in scleroderma from Kearney et al., as I've listed there, about the early institution of mindfulness practices being vital for self-management of emotional burden. And these mindfulness practices could vary depending on cultural beliefs, religious beliefs, practice patterns, and what patients may have experienced. So some examples I could give you here are things like yoga, Tai Chi, meditation, going to the church, going to your own religious centers, volunteering, or it could be gardening or spending more time in the kitchen. All these are important mindfulness practices, provided there is self-awareness during each of these practices when done. There are many mobile health applications that are proponents of mindfulness, some of which I have used, including Calm, Headspace, etc. Next slide, please. Of course, there could be impact on roles in the professional life. There is a high prevalence of work disability, up to 46% within the first few years of diagnosis, especially with diffuse disease. Now, this is an important point. Often we see men being the sole breadwinners of the family. That really impacts the whole family income. So being in gainful employment is an important aspect of things. Next click, please. And based on data almost 7 or 8 years ago, the Association of Work Disabilities seemed to have a link in terms of lower educational level, presence of lung involvement, either lung fibrosis or pulmonary hypertension, lot of fatigue, severity of the disease, and a lack of good social support for all the reasons that I mentioned before. Next click, please. Work disability is closely also linked to self-perception of health and disability. In other words, being able to work through the diagnosis and treatment has its own positive impact and positive empowerment on one's mind and one's self-management and one's perspective of the disease. Next slide, please. Often patients do tell me that jobs involving public speaking, it does become a whole lot more burdensome, especially with frequent travel, it could be, or with issues with the face, the facial changes, dry mouth and decreased oral aperture, altered dentition, all of these. So that's some aspects or points to consider, and could consider lifestyle modifications around this. Next slide, please. Some interventions to consider upfront are being transparent and informing your employers and some of your closer colleagues in your team about the diagnosis. Proactively reaching out to the HR at your workplace, talking to them about what are your options in terms of either work hour flexibility, lesser work intensity, ergonomic modifications. So for someone sitting in front of a desktop computer all the time, using a mouse and a keyboard, can we have simple modifications so that you don't have to use your fingers so much? Avoiding occupational exposures if possible. So those welders, people who are all constantly exposed to organic solvents, fumes, and silica, requesting if there is an option to move them from these exposures. Next click, please. So those are some of the things I try to tell my patients from an employment perspective. Now, in collaboration with the University of Michigan Scleroderma program, the University of New Mexico Scleroderma Foundation, Scleroderma Research Foundation, and PCORI, we've developed something called self-managed scleroderma. I've given the website information, wherein it's an internet-based self-management program, and it is to empower our patients to take charge of their condition. I would encourage as people with the established diagnosis as well as the new diagnosis to look into the website and try to go through this program. Next slide, please. Now I want to switch gears and dwell a bit more into the individual organ involvements, some self-management tips, some education on what is the current standard of care. And I have included these yellow boxes that talk about what are the current ongoing clinical trials at University of Michigan. So in terms of skin involvement, we know that there is hardening. Why is there the hardening that happens? Now, there are a lot of lab-based translational studies that are ongoing, discovering new things, new components about our immune system, and how these cells and chemicals talk with the skin, the tissue beneath the skin, and why the hardening happens. But one thing that we know is there is excessive buildup of collagen, along with a varying degree of inflammation depending on the stage of the disease. Now, we have sweat and oil glands in our skin. If you're hairy, it's a bit more. And that can, the involvement of these sweat and oil glands can certainly lead to a lot of dry skin along with the stiffness and hardening. Patients often complain that they use moisturizing lotions, they still have dry skin. My usual recommendation is it's important to use moisturization with oil-based creams or lotions. I usually tell my patients to avoid lotions because they're more liquidy, there is more alcohol content. Even the alcohol-free lotions are not enough to moisturize the skin. So I like the cream-based lotions, something like a fragrance-free cream like Cetaphil or Lubriderm, etc. Certainly avoid harsh soaps and extreme water temperatures. Next click. You could use humidifiers, especially during those winter months when you have your heating up. But to avoid dry skin, you can use the humidifiers to help the skin soft with moist air. Wearing protective clothing and sunscreen. Next click, please. You may want to consider, if this is practical at all, bathing less if your skin gets seriously dry. So that could be, based on your schedule. If you're bathing twice a day, doing it every day, or you can do it every other day. And eat foods rich in vitamin E, such as nuts, seeds, wheat germ, olive and peanut oils. Now, the skin involvement is assessed, again, as I said, based on a skin scoring system called Modified Rodnan Skin Score. Rheumatologists trained with the skin scoring method, we pinch the skin at 17 different body areas, and at each body area, we score from 0 to 3, 0 being no skin thickening, 3 being very thick skin, 1 is mild, 2 is moderate. Now here in this picture, you can see on the right, it's easy to pinch the skin, but not so much on the left. And this is what we see in our patients. The current, and what we do at each visit is do the skin scoring, log the score, and compare the score to the previous visit, and make treatment decisions based on the skin scoring. The current treatment approach in patients with systemic scleroderma, and irrespective of diffuse or limited, who have hand contractures, is to upfront send them to occupational and hand therapy to help preserve the muscle strength in the hand muscles. Because any treatment is not going to completely bring back the complete hand function. So early institution of occupational and hand therapy is important. We use immunosuppressive therapy. Please go back to the previous slide. We use immunosuppressive therapy, so medicines to suppress the immune system, like mycophenolate mofetil. The market name is Cellcept, quite extensively in people with diffuse scleroderma. Now, some patients with early onset of the scleroderma, so if they're within 1 to 2 years of the disease onset, and they have a limited skin involvement, but they have these patterns that tell us that they might progress to a diffuse pattern, we may proactively use mycophenolate mofetil. Methotrexate, a medicine that has been used historically to treat rheumatoid arthritis, has also been used, and we rarely use it, especially if there is concurrent joint inflammation. We have ongoing and upcoming clinical trials specifically for people who have diffuse systemic sclerosis, usually within about 4 to 5 years of disease onset, at University of Michigan Scleroderma program. Next slide, please. Now, I would like to take this opportunity to talk about the much discussed and debated intervention called the stem cell transplantation for diffuse skin involvement. Now, on the right is a figure that I borrowed from the Leukemia and Lymphoma Society to explain what this process means of stem cell transplantation. Stem cells are immune cells that are present in the bone marrow. So step one, usually there is mobilization of these stem cells. So there are certain drugs given that will move the stem cells from the bone marrow into the bloodstream. And then in step two, there is a process of collection of these stem cells from the patient's own circulating blood. And these are processed and saved. That's in step three, and they are frozen. On step four, the patients are then given high-dose chemotherapy with or without radiation therapy. And this is done to kill any remaining immune cells. There is a mention of the word cancer cells. That's because I borrowed it from the Leukemia and Lymphoma Society. But in the context of scleroderma, the chemotherapy and radiation therapy is given to completely wipe out the immune system. And then the frozen and the processed stem cells or the immune cells from the patient's own immune system is given back or reinfused into the patient. Now that is the process of transplantation. So we call this whole process autologous, which means from your own body, stem cell, which is the immune cells in the bone marrow, transplantation. So it's like shocking the immune system and resetting it. That's the best way to describe this process. There has been interest for many decades about stem cell transplantation in systemic sclerosis, specifically in diffuse systemic sclerosis. And the focus has been in those patients wherein you've tried first or second line of immunosuppressive therapy, yet they're quite refractory to these treatments and their skin continues to progress. So there were 3 clinical trials that were conducted in different parts of the world. As I've listed, it's called ASSIST, ASTIS, and SCOT. Next. Click, please. All the patients had diffuse skin involvement, and they usually had a disease duration of less than 5 years. And most of these patients had tried other immunosuppressive therapy, or they were on concurrent immunosuppressive therapy. In response to stem cell transplantation, they had remarkable improvement in their skin scores. In those who had lung involvement, they had stabilization of the lung disease. There was a better survival, or what we call an event-free survival. However, there were variable percentages or rates of death reported in patients who received stem cell transplantation during the process, especially at step 4, when they were given high-dose chemotherapy or radiation therapy. In the SCOT trial, there were almost 2%, 2 out of 100 or 1 in 50, while in some of the other trials, it was up to 10%. Next slide, please. Now, the yellow box. So we have a number of ongoing clinical trials. This is for your information. I have included the clinicaltrials.gov identifier, which if you were to go to the clinicaltrials.gov website, you could copy and paste it and know more in detail about these trials. So trial 1, we will be starting recruitment for the next phase soon. Trials 2 and 3, we are currently recruiting. Now, again, going back to the previous slide, I must mention that we have completed some trials recently, some of which the data analysis is ongoing, and we should have some publications soon from it. These trials have included medications like abatacept, which is Orencia, tocilizumab, which is Actemra, and tofacitinib, also called Xeljanz. All these three medications have been approved for treatment of rheumatoid arthritis. Next slide, please. Now, I have brought in sexual life and erectile dysfunction very early in the description of this talk, as it pertains quite commonly to all our male patients. Sexual life is a very important component of the quality of life. Now, this can clearly be affected due to scleroderma, as there is altered blood flow in the penis. There is fibrosis or scarring that happens in the penile tissue that leads to erectile dysfunction. Now, erectile dysfunction is defined as the persistent inability to attain or maintain a penile erection, which is sufficient for sexual intercourse. First reported in 1981, over 80% of men report erectile dysfunction. This is men with systemic sclerosis. 30% have severe form of erectile dysfunction. Next click, please. So the first and the foremost thing, we won't know until you tell us, so please talk to your rheumatologist and also your primary care physician, as we in partnership consider other causes of erectile dysfunction. It could be long-term smoking, use of certain medications, diabetes, hypertension, prostate problems, etc. The modifiable factors wherein you can control your life include things like smoking. If you have gout, or even without gout, if you have a high uric acid levels, ways to change your diet to lower it. Weight loss in people with high body mass index. And if there is high blood pressure, optimizing the treatment of that. Specific treatments for erectile dysfunction, we something called PDE5 inhibitors, sildenafil or Viagra. There are longer acting options called with medication called tadalafil, which has a similar mechanism of action, also called Cialis. We often refer our patients to a urologist quite early, especially in severe forms of erectile dysfunction, and where patients are open to some interventional procedures like vacuum-assisted devices, penile injections, and surgical options. Although these are usually not the first line, their second line also depends on weighing the risks versus benefits. Next slide, please. I would like to move on to one of the common manifestations, the Raynaud's phenomenon, wherein there is vascular changes or blood vessel changes in the smaller blood vessels in the hands. Here we have a picture that shows the different color changes that happen in sequence. The top picture shows loss of blood flow, causing the affected areas to first appear pale and white. This is almost always in response to the ambient temperature, so the temperature around you. So this can also occur in summers when people go from a warm exterior to the cold interior when the air conditioning is on. So this first phase is due to what we call constriction of the blood vessels or vasospasm. If this persists and patients don't notice it, it can turn blue or dusky or purple from a lack of oxygen supply. And almost always patients have symptoms during this time wherein they have pain, burning, tingling, etc., that prompts them to go and warm their hands with washing under warm water or kind of waving their hands over steam. And then the blood flow is restored, and then the fingers turn bright red. Now, what are some of the self-management techniques here? Keeping your hands warm, especially when you anticipate a cold exterior temperature. In addition, wearing clothes that are warm. So we need core body also being warm. So layered clothing, hats, mittens, etc. also help. Plan your day, avoid prolonged cold exposure if possible. And if you smoke cigarettes, please stop, because that's going to make the vascular disease worse. Now, when someone mentions Raynaud's phenomenon and we are trying to diagnose scleroderma early, we do this technique called nail fold capillaroscopy, as I mentioned earlier, using this device called a dermoscope. Next slide, please. We do not have any FDA-approved medications for Raynaud's phenomenon. Medications commonly prescribed include some blood pressure medications like amlodipine, also called Norvasc, or nifedipine, also called Procardia, which have variable benefit, to be honest, in the treatment of Raynaud's. We sometimes combine an antidepressant called fluoxetine with some benefit. The most benefit we have is again with Revatio or Viagra, the compound in them being sildenafil, or tadalafil or Cialis. We have an ongoing clinical trial at University of Michigan wherein we are trying to look into this medication called iloprost, given intravenously for 5 days in patients with symptomatic Raynaud's phenomenon, all having systemic scleroderma. Iloprost is approved in the European Union for treatment of Raynaud's phenomenon and digital ulcers in systemic scleroderma. So we are currently, this phase, we are going to start recruiting in October 2019. Next slide, please. Digital ulcers or ulcers in the fingertips is seen or has been reported by our patients, or up to 50% of our patients in having an ulcer at some point during their entire diagnosis. This is from continued poor blood flow to the fingertips. Now, this is tightly linked with the process underneath the Raynaud's phenomenon. So one of the key things when you have an ulcer is to keep skin moist and supple with creams, ointments like lanolin, but when you apply, to make sure that you have a very sterile technique and not to make sure you wash your hands, or if your caregiver is applying it, make sure they wash their hands before they apply. Protect the fingertips, treat any cuts that come on promptly and thoroughly, and important to optimize the management of Raynaud's phenomenon. Keep your physician involved at all times, especially when you have an ulceration, and let him or her know when an ulcer has started. The earlier it is treated, the better it is. We have a team-based care wherein we involve wound care, our hand and plastic surgeons to be involved early if needed, and there are treatment options available. Next slide, please. Early so digital ulcers, apart from our initial treatments, we sometimes hospitalize our patients for intravenous treatment. In addition, we take the help of our plastic surgeons for interventions like Botox injections or another procedure called sympathectomy. Hand and joint contractures are quite common. And as I said earlier, it's important to have an early involvement of our occupational therapist. A well-designed program of regular stretching, gentle exercise, under the direction of an experienced physical therapist becomes important to minimize joint contractures and improve circulation. Next click, please. We have an ongoing clinical trial at University of Michigan wherein our occupational therapists are looking into either a intensive face-to-face well-designed occupational therapy program works better over 8 weeks as compared to a mobile health application wherein patients are taught and they do it at home. And that's what we are trying to compare. This is called the REACH study, and we are currently recruiting. Next slide, please. Next, I would like to move on to the lungs. Lung disease, what we call interstitial lung disease or lung fibrosis, as I said, is seen in many of our patients with systemic scleroderma. There are certain risk factors for development of ILD or interstitial lung disease, like, for example, the presence of this antibody called SCL70. Your doctor, so the rheumatologist, will often regularly check for A, any symptoms that you might have, like difficulty breathing or cough, and B, lung function test to see how your lungs are functioning. At University of Michigan, we make it a point to screen all of our patients who come in as new patients with systemic scleroderma by obtaining a high-resolution CT scan of the chest to diagnose lung disease early. And this is irrespective of them having any symptoms. We have several observational studies in scleroderma lung disease, one in collaboration with other scleroderma centers. We are trying to understand in patients with lung involvement due to scleroderma who have progressive versus somewhat of a non-progressive kind of disease. We also have an observational registry wherein we are prospectively enrolling our patients and trying to understand their unique characteristics in terms of their blood tests, their symptoms, their CAT scan findings, their lung function tests, and quality of life impairments. Next slide, please. What can you do? Again, I'm going to say stop smoking. It's important to improve the management of gastroesophageal reflux disease or acid reflux, which I'll come to it at a later slide. And physical activity as tolerated is important. The current treatment approaches for patients with lung disease, again, we use mycophenolate mofetil or Celcept, intravenous cyclophosphamide or Cytoxan in case of a progressive form of lung disease, intravenous rituximab in some refractory situations. Recently, a medication that was approved for a related lung condition called idiopathic pulmonary fibrosis or IPF. The medication was called nintedanib. It has been tested in our patients with scleroderma lung disease and has been shown to stabilize the lung disease. Next slide, please. Finally, we have an ongoing clinical trial at University of Michigan called the Scleroderma Lung Study 3. This is a national study. It's being opened up in many centers in Canada also, wherein we are looking into combination treatment with pirfenidone used for treatment of idiopathic pulmonary fibrosis as in combination with Celcept. Next slide, please. Along the lines of lung involvement, you can have pulmonary hypertension, as I said, which is high blood pressure in the lungs. And screening for this particular condition is the most important thing. And this we do with a combination of blood tests, the lung function test, and the ultrasound scan of the heart. And we kind of compute all these parameters into a complex algorithm that gives us a score as to whether patients need referral to a specialist in pulmonary hypertension. If the concern is high, we refer to a cardiologist, or in some centers, a pulmonologist who specialize in pulmonary hypertension. And the patients may need something called a right heart catheterization to diagnose this condition. Once the diagnosis is confirmed, there are several treatments now approved for treatment of pulmonary hypertension. Next slide, please. Now, the gastrointestinal tract, and John, I'm going to ask you to go ahead and populate all the points. Gastrointestinal tract from mouth to rectum can be affected in 9 out of 10 patients with systemic scleroderma. This can start with a decrease in the oral aperture or being able to open the mouth as wide as they can, change in the dental care and change in the dental environment, frequent cavities, dry mouth, difficulty swallowing foods, pain while swallowing foods, a lot of acid reflux, bloating after you eat food, diarrhea or constipation, and sometimes inability to control the passage of stools, what we call fecal incontinence. There is no single way to diagnose all of these apart from asking patients very carefully. Dr. Khanna, developed and patented a questionnaire that we use commonly to understand the different segments of the GI tract affected in patients based on their symptoms. So some of the things we commonly tell our patients is to eliminate foods that give you heartburn or gas. Heartburn needs to be optimally managed with medications like omeprazole or Prilosec or ranitidine. But most importantly, lifestyle changes are important. So we recommend our patients have small, frequent meals and emphasize moist, soft food, and drink liquids while eating and chew foods well. Also, eat the last meal of the day. If you could go back to the previous slide, at least a couple of hours, 2 to 3 hours before you go to bed. And avoiding to lie down after a meal and have your head end of the bed elevated to at least 30 degrees or more by the use of a wedge pillow or raising with a brick in the head end of the bed. Now, I have included many links in this slide, and all of these are to help you learn more about self-management from a GI tract involvement perspective. Next slide, please. Dental and mouth problems are frequent. It's important to maintain a close follow-up with your dentist, dental hygienist, and even an occupational therapist who sometimes can be quite innovative in devising effective ways to brush, floss, and maintain daily oral hygiene. Drink liquids, particularly water, throughout the day. I must warn that any form of soda has a lot of sugar and has a high tendency to make the acid reflux worse. Try to avoid alcohol, tobacco, dry bulky foods, and mouthwashes that contain a lot of alcohol, which can all cause dry mouth. Brush or rinse after eating to keep the mouth clean and moist. And for more serious mouth dryness, salivary stimulants or substitutes are available. You should talk to your doctor about it. Sometimes occupational therapists can help with some facial exercises that are considered effective in promoting flexibility of the mouth and face. Next slide, please. Kidney problems, what we call scleroderma renal crisis. I don't think this is a typo. I'm not sure why there are some of these headings coming right next to the kidneys. Scleroderma renal crisis is not so common, yet a very serious condition. It's one of the emergencies that we get called for. If you are determined to be a patient at risk, commonly it's people with early diffuse form of scleroderma with a particular antibody called RNA polymerase 3. You should learn how to measure your blood pressure, check it every day, every morning, keep a log, and if the upper number is at least 15 to 20 points more than usual, and the bottom number is 10 to 15 points more than usual, you should inform your doctor. Certain medications should be avoided or minimized. These include glucocorticoids or steroids, and preferably any NSAIDs like Aleve, Advil, naproxen, etc. And we also suggest caution with cold exposure, as it may reduce the risk, although the data is not so strong. Next slide, please. That was pretty much overview of my presentation. I think I'm 5 minutes over. My hope was to give at least 30 minutes for questions, discussions, etc. We have a big team, as you can see here. Our leader and director is Dr. Dinesh Khanna, and the clinicians include me, myself, Dr. David Ruffey, who just joined us, and Dr. Amber Young. And our research team includes this fabulous set of professionals. Ms. Bush, who is our program manager. Some of you have met Monica Sanborn, who's an RN and a clinical coordinator, and Dr. Sarah Jaffer, who's also a clinical coordinator. And Maya is our subjects coordinator, and Mr. Reddy is our data analyst for all our data. And they make our life really easy when we are trying to do our clinical trials and research. Thank you.
Thank you so much, Doc. John, was that you?
Yeah, I was just going to say, Doctor, fantastic presentation. Let me say thank you for first before Michael jumps in. And I will ask everybody is that if they have a question, they can unmute yourself. And like I said, hopefully we can have an orderly group. And like I says, I will ask the group if there is any questions. Michael, we'll start with you.
Well, it's good. The first question I wrote down is I've done a lot of some reading on this, Dr. Nagaraja, and I have no clue if this is pertinent or if there's any backing about it. That in especially men with scleroderma, that they have chromosomal changes in their DNA. It's different from the normal man. Is that true, or is there any documentation on that, or just something that's out there on the internet?
I think there is a lot of studies done, not only at the chromosomal level, but how the environment affect the genes. We call it epigenetics. In addition, looking into some of the proteins and the RNA that's produced in one's body. I don't think there's any convincing evidence to say that there are recognizable changes up front that could actually lead to understand the risk of scleroderma. However, once they develop the diagnosis, there are some changes seen in some specific proteins, but yet it's still very early to comment on what's the downstream impact on diagnosis, treatment, or subtyping, etc. But there is a lot going on in that area for sure.
Certainly. Thank you.
But I must make a comment there before I go to the next question. There has been some seminal work that's been done by Dr. Mike Whitfield in partnership with Dr. Dinesh Khanna, as well as a rheumatologist down in Texas. And they've been looking into different patterns of our gene expression, which again kind of links back to the chromosome and the DNA. And they've found some very different patterns of gene expression in someone who may have a very lot of inflammation in their early part of scleroderma versus lot of fibrosis or scarring versus lot of versus neither. As in, when you look at someone having normal skin and someone having diffuse scleroderma, some of their gene signatures might almost look normal. I'm not saying the skin looking normal, but gene expressions looking normal. So there is a lot of good work that's going on right now. We should have more in the coming years.
Thank you. Thank you.
I'm going to unmute the group, so if there's any questions, you'll be able to ask directly. So let's see. All participants are now unmuted, so if you got background noise, you can remute yourself, or like I said, if you have a question for the doctor, please speak up. All right, you can't be shy, guys. Well, we're always the ones who can always take it, but I'm sure there's some questions out there about some of the discussions that were brought up tonight.
While they're waiting, Raynaud's, the effect obviously is in the hands and the feet. Other issues, I've seen it on the Sclero-Men webpage about men that have symptoms of Raynaud's in their penis. Mine, you know, I mean, I'm not talking about that for me, but I can't swim anymore in like a lake because if the water is not a warm temperature, I basically kind of go into shock and it brings on a Raynaud's attack. So just avoid that. But it feels like my chest is going to explode. So is that a symptom of Raynaud's? And then going back to the male aspect of Raynaud's in the penis.
Yes. So, you know, usually the Raynaud's happens in cooler areas in our body. So cooler areas. So that's why we see it in the fingers, the toes. We see it on the ears, tips of nose. And yes, it can happen on the penis. And it's important to note that, again, I want to underline the point that yes, it happens in winter, but you see a lot, you all may have experienced that it happens a whole lot in the summer too. And it's really the change in the surrounding temperature that brings it on. So it is a lifestyle modification. I don't have any other best way to answer. If someone who really loves swimming in the lake, you just have to watch out until either the water is warm or you have to kind of start doing it in a warm pool to avoid these kind of attacks. But again, I ask my patients, because is Raynaud's bothersome is a common question. And I turn back and ask them, is it bothersome to you? Is it bothersome because your hands are always cold and your loved one doesn't like to be touched? Or is it because you just don't like to see those color changes, or because others say that, why are your hands turning white? Or is it actually because with these color changes, you have a lot of symptoms, which is often the most common reason for being bothered by it? The pain, the stinging pain, the burning, etc. So treatment for Raynaud's depends on how bothersome the symptoms are.
Anna, you have a question. Why don't you ask the doctor? I see your hand up.
Hi,
Hi, Anna.
I'm from Mexico. My son, the last year at age 50, was diagnosed with Scleroderma, Scleroderma, but I cannot find information about male adolescents with this disease and its prognosis. He has pulmonary, gastrointestinal, and neurological involvement. Also, he had a lot of pain in her body, and he tried to go to the high school, but if he go one day, he stayed 3 days in a bed. Where can I find information?
So let me try to rephrase this question, and please correct me if I'm wrong. You're saying that your son has systemic scleroderma, but it's cine scleroderma. He doesn't have skin involvement. Am I right?
That's correct.
And he has internal organ involvement. You said the lung, and I missed a couple of others.
Gastrointestinal and neurological.
And neurological. And may I ask you, how old is he?
16 years.
So very young, very young. And where are you calling from, Anna?
Monterrey, Mexico.
Monterrey, Mexico. So first off, it's a very young age to see systemic scleroderma. I have probably a couple of patients at such a young age. One of them actually was a pediatric onset, which means they were very young when it started. So it's not unusual, but it's quite uncommon. The prognosis. So first of all, I must say that neurological or brain involvement is almost never seen in systemic scleroderma. Whenever there is neurological involvement, we start thinking about overlap with other rheumatic diseases like lupus, or is there Sjogren's disease or something else on top of it. So that's a question number one to clarify, because that can have an impact on the treatment plan. Secondly, in terms of prognosis, we don't have a lot of data to say that patients with thinning scleroderma might be different to some of our other subtypes. That said, because of the challenges with diagnosis early on, it's just a difficult population to look further into treatment. But I would say that in terms of internal organ involvement, the prognosis would be quite similar to some of the other subtypes. And it also depends on the severity of the organ involvement. So I think you should probably go back to the rheumatologist treating to discuss more about clarifying the neurological involvement and why does he just have to be so fatigued, and if there are other reasons that could explain that.
Thank you.
Sure.
Have a question.
Sure.
My name is Alex.
Hi, Alex.
I'm just like fresh. I've been diagnosed like a year ago. I have overlap conditions. It's Scleroderma, RA, myositis, and ILD. My myositis panel is clean. I have some RO52s, SSA 60s, antibodies, regular ones. Currently on CellCept 3000 units, prednisone, little dose, amlodipine, and that's it. The primary concern and discomfort I'm experiencing is a tachycardia. And my doctor was hoping that when the CellCept kicked in 100%, and the prednisone, everything else, my heart rate will slow down, but it didn't. So I checked each and every possible direction. So a general one. So I did echocardiogram. It's normal. I did the Holter monitor. It's no arrhythmia. Yes, I have a 160 rate, and during nighttime also. I checked my oxygen level during, the oximetry, the nighttime. It's also normal. The last one I did, it was CT chest for the blood clots in lungs. No blood clots in lungs. So what else? That's probably it. All the blood work they checked, no indications which are supporting the simple tachycardia reasons. So I don't know. I had a discectomy on the cervical level, but it was 15 years ago. I mean, I had the same issue with the tachycardia, but after the surgery, it normalized. And the last detail about it, I've been checked for the cardiac. I had a cardiac test last August. My heartbeat was 65-60, which was normal. All the blood vessel sizes were normal. And that's it. That's all details. Tachycardia, what can we do?
Alex, may I ask you where you're calling from?
New York.
Oh, okay. So thank you for the details. And And thank you for participating. It's quite a challenge having overlap of rheumatic conditions. Now, I'm going to dive right into the question about tachycardia in the interest of time. Cardiac involvement, especially the conduction system, can be seen in scleroderma, as I mentioned. You tell me that the Holter monitor was abnormal because I wouldn't expect a heart rate of 160 unless it was associated with extreme exertion. Was that at rest that 160 event happened?
Yes, it was. I mean, 165 during the nighttime.
Okay, so that is abnormal. So, couple of thoughts I have is one: have you had an MRI of the heart? It's called a cardiac MRI.
Not yet.
Okay, so cardiac MRI gives a lot more information about the heart muscle, and it's usually done with contrast, with a dye, and it can show areas that might enhance in the heart muscle that sometimes could be close to the conducting system. So that's something we do in these situations. So that's something I would recommend discussing with your rheumatologist or cardiologist. The second thing is considering doing, you said have you had a stress test?
Everything.
You had a stress test.
Everything is good. And last August, I had it. My pulse was okay. I had a couple of stress, periods with a high level of stress. That's the only triggers I can,
And your Holter monitor was for 72 hours, or was it for a week or a month?
No, just for 24.
So sometimes doing it for a longer time can pick up these abnormal heart rhythms and kind of patterns, which would give us more information. I've seen some of my cardiology colleagues, especially those who specialize in conduction abnormalities, they do it for an extended period of time. They do it for 3 days. So 72 hours or even up to a week. But definitely I would recommend a cardiac MRI in this situation.
Okay.
And then, then obviously if there is any suggestions of inflammation, we go on to do something called a cardiac biopsy. So they get a small sample from the tissue to look for inflammation. And then that might indicate a need for a more stronger immunosuppression like cyclophosphamide or Cytoxan, plus or minus the need for any other procedures from the cardiologist standpoint, like a defibrillator or pacemaker. That's all dependent on the kind of rhythm they see on the Holter.
The Holter shows no arrhythmia. The normal rhythm during 24 hours, except high rate, 100, 160. That's it.
So sometimes, they have seen them use just beta blockers as to just control the heart rate. But the challenge becomes if the increase in the heart rate is quite episodic as opposed to being constant. That's where it becomes a bit of a challenge. But I would at least start with the cardiac MRI and maybe discussing if a longer duration of Holter monitoring is needed.
Okay. You mentioned, I have another kind of question.
Sure.
BDs, I mean blockaders, they usually not recommended. My cardiologist from New York Presbyterian mentioned that it's not very good way to use them considering my ILD condition.
Which one? I'm sorry.
The beta blockaders or whatever you call it.
The beta blockers. No, the beta blockers. You're right. I think it's not appropriate, especially for Raynaud's. But there are other medications that they can use. Some of them are calcium channel blockers that could help with the heart rate. But I think it should be done in consultation with your cardiologist.
Yeah, because both I went to see two of them.
Okay.
Both of them, I asked, what's going on? They say, we don't know.
It's challenging. I've faced this kind of discussion with some of my patients, and given the rarity and the fact that we don't screen heart involvement as proactively, I think things are changing now. It also is a rare presentation for cardiologists that they may not often think about. And it also needs a bit of parallel thinking to see, is this related to scleroderma or could this be something else? That's also important because you have enough going on. There could be other reasons.
Very good point, because I had a feeling, very strong one, because I had a big issue with the herniated disc and the major surgery. And I have a lot of spasms in my muscles, in my joints on the left, on the left side because of that. So it also will come up as a huge inflammations because they all in spasms, still in spasms. In every spasm in a muscle or joint or ligament will increase the heartbeat. Am I right?
It can, yes, as in depends on the intensity of the pain and the symptoms. But then if you're sleeping at night and all of a sudden the heart rate is 160 and you don't even know about it, that is something that needs to be looked at.
Okay. I'd like to right now ask if there are any other questions within the audience, as well. We are coming up against our 8:30 time, as well as we really appreciate the doctor giving us his time tonight. Is there any other questions from anyone else?
Nope, just the closing, John.
Why don't you do that, Michael?
Okay. At this time, we're going to thank Dr. Nagaraja for his time and the incredible presentation that he provided with us. And I look forward to meeting you again and seeing you down at the U of M, sir. And this one went a lot smoother than our one a year ago. So thank you very much. And we switched providers, and I think this is a lot better format. So thank you very much for all you do, and especially for the scleroderma community. So I'd like to thank all of our participants, and staying educated about scleroderma is so important and can benefit scleroderma patients. This is the reason that the Michigan chapter strategically has created this web-based educational experience. Being educated can help the scleroderma community become better healthcare advocates. October 3rd will be the next webinar for the families and friends of pediatric scleroderma patients and those wanting to learn more about how scleroderma can affect younger individuals. Dr. Catherine Torek, the director of the Pediatric Scleroderma Clinic Children's Hospital of Pittsburgh, will be presenting on the topic, Managing the Needs of a Pediatric Scleroderma Patient. This will be another informative and educational live webinar that will be for the scleroderma community. Thank you again for sharing your time on this webinar, and thank you everybody, and have a great evening.
Thank you very much, Doctor, and we really appreciate it. And thank you to everyone. And as you can see, we had Mexico and Europe chime in, and along with Michigan. So from that standpoint, obviously the presentation is touching a lot of people globally. So, Doctor, thank you very much. And with that, I'm going to say we're going to wrap this up for tonight.
Thank you very much, Doctor.
Thank you, folks.
Thank you, John and Michael. If you could please send me a link to the recorded webinar. I just have some colleagues from around the world who would like to have access to it.
We will have we will send that to you in a day or two once it's posted on the web.
I appreciate it. Thank you.
Thank you very much. Have a good evening, or some of you a good night. So, bye-bye.
Good morning. Good night.
Bye.